Thank you so much. I'm very happy to see in Hindi team discussion and more people in the Hindi team. I'm appreciating Sahani sir for his effort and dedication to IFPH. Thank you so much. Really love to see all this. Thank you so much. We are moving to English session. Today is our 1506th day of continuous webinar. Thank you everyone for participating with us. Thank you all the faculties for sharing your knowledge here. Today's our guest is Dr. KULWANT SINGH. He is an ex-Deano and faculty of homeopathy in Vinoba Bhabhe University, Jharkhand, and he was a principal in Singh Bum Homeopathic Medical College Hospital, Jamshedpur, since 2000. And he has 43 years of teaching experience and presented several papers in several seminars in nationally and internationally, and ex-chairman of Homeopathic Literature Committee, ex-member of Educational Committee of CCH, and ex-inspector of Central Council of Homeopathy, and examiner and paper setter for several universities. And many I have to say about Dr. KULWANT SINGH. He's a resource person of Ministry of Ayush, resource person of Central Council of Homeopathy workshops. And I'm proudly we are inviting Dr. KULWANT SINGH for our webinar. Thank you so much, sir, your presence here in IFPH. Thank you so much. You're welcome. You can start now.
Welcome back, Dr. KULWANT SINGH. This is the first part of his hypertension lecture. Dr. KULWANT SINGH will be presenting this lecture in two parts.
My homage to late Dr. Mahendra Singh ji. I had the fortune of meeting him several times, and Dr. Mahendra Singh ji stayed at my residence 2 to 3 times. So whatever I got from him.
Sir, excuse me, KULWANT SINGh, sir.
Yes, ma'am,
yes. Your sound is feeble. Can you? I think you can increase the sound in the computer. I think it may be.
Is it okay now?
Yeah.
Thank you. And my pranam to Dr. Arun Bhashma ji. I am saying he is present. Very rarely we find Dr. Arun Bhashma to this meeting. Sir, pranam. Aapko mera bahut pranam. And now we
pranam, sir, pranam.
And now we shall start our presentation. So I'll be giving a small lecture on hypertension. So hypertension is such a vast subject, it is very difficult to summarize it in 40 minutes, but I will try my level best to give you some for hypertension. The hypertension, before going hypertension, it is directly related with the heart. So there are some hard facts about heart which we should know, which nobody or some of us might not be knowing. So hard facts are there that the heart can beat outside the body. You must have seen several places, several surgeries that heart can beat outside the body because it has its own connective tissues. It has its own elective tissues by which it can beat outside the body also. The blood vessels, if combined completely in our body, the total blood vessels, capillaries, veins, venules, they are about 96,500 kilometers, which can circle the earth 2 times. And the poor heart is pumping the blood 70 to 80 times in these capillaries, 96,500 kilometers. Human heart beats about 1 lakh times per day, pumping roughly 2,000 gallons of blood through the body, which is enough to fill an 8 by 10 foot swimming pool. We are having a small heart. We are having about 5 liters of blood in the body, but the total circulation of the system, 5 liter blood in the heart in the day, will fill an 8 by 10 foot swimming pool. The heart pumps blood, we know that, all of our body, yes, but But you must know, except cornea. Cornea is a part in our body which is not receiving blood from the heart. It takes oxygen directly from the air. And from the air, the oxygen goes and then it mixes with the blood. And we have a brain in our heart. The heart contains about 40,000 neurons. And these 40,000 neurons in the heart, they send signal to the brain and can influence emotion, stress levels, cognitive functions, positive functions. This is sometimes referred to as heart-brain connection. And we always use the word atrium and ventricle. The atrium is a Latin for entrance hall. We know from the atrium, blood enters into the heart. Everybody knows that blood enters into the heart from the atrium. And ventricle is Latin for little belly. The blood goes and collects in the ventricle. And when it collects is in the ventricle, it sometimes swells up. So that is why it is known as little belly. Now come to the heart. What is blood pressure? You must understand what is
all
the
that blood exerts a force on the muscular walls of the blood vessels.
While
That
flowing,
force is called blood pressure,
on
and
the
it
artery
rises
wall.
and falls
That
with
is
the
known as
phases
the
of the
blood
heartbeat. It's highest during systole,
blood
when
is
the heart
flowing.
contracts to force blood through the arteries. This is your systolic blood pressure. When the heart is at rest between beats, the blood pressure falls to its lowest value, the diastolic pressure. A typical healthy individual produces a systolic pressure between 90 and 120 millimeters of mercury, and diastolic pressure between 60 and 80. Taken together, a normal reading is a bit less than 120/80. All that blood exerts a force on the muscular.
So this is very clear now that what is the blood pressure? It is the pressure of the blood while flowing from the arteries being exerted on the artery walls. It is not the pressure in the heart, which everybody thinks. Okay, there is high pressure, oh, the heart is not pumping properly, the heart is pumping. But the pressure is measured by the flowing blood in the artery walls laterally. When it flows into the artery, when it exerts pressure laterally on the artery wall, that pressure is known as the blood pressure. During systole, it is more, it is known as systolic pressure. During diastole, when the ventricle relaxes, when the heart relaxes, it falls down to a bit, that becomes a diastolic pressure. So this is systolic pressure. Maximum pressure during systole. When the heart contracts, the maximum pressure is systole. When the heart relaxes, the pressure is diastolic pressure. Difference between systolic and diastolic pressure is known as pulse pressure. So this pulse, diastolic, systolic should be 1:2:1. If the systolic is 120, this is 180, this is 40. And sometimes you will have the word mean pressure. So mean pressure is arithmetic mean, roughly. It is not exact. I will not go into the detail because it will take a lot of time. But roughly you can understand that arithmetic mean, systolic plus diastolic divided by 2 will be mean pressure. Try to understand this thing very, very properly, because this will help you to understand what is happening, what is blood pressure, how it is increasing, how it is decreasing. So blood pressure depends on two factors. Our blood pressure depends on two factors. One is cardiac output and one is peripheral resistance. Cardiac output is the amount of blood which is being pushed from the ventricle. This is the left ventricle. This is the left ventricle. This is the ventricle during systole. This is during diastole. When during systole, the left ventricle contracts. When it contracts, this is contracting. So when this ventricle walls are contracting, we know that ventricle contraction is for 0.3 seconds. A ventricle dilatation is for 0.5 seconds. So this is for 3 seconds, it has to pump the blood to the body. Because during diastole, it is not pumping the blood. So in 0.3 seconds, it will have to pump the blood to the body. So it is contracting. You can see this is contracting and the blood is going here. This is the aortic valve. Due to the pressure of this blood, this valve opens and the blood goes to the aorta and the body. These are the small arterioles of venules. This is the circulatory system where the blood is going from the, you can see from the system. From the ventricle, the blood comes here, this valve opens and this mitral valve closes. When the cardiac output, it is having cardiac output, the ventricle is contracting, this valve closes. So it cannot go back to atrium. This cannot go back to atrium. This is atrium. So it comes here, goes here, goes here, goes here, and then to the circulation. Now this is due to the pressure. And this pressure normally in the heart is 120 millimeter of mercury. So when it presses this pressure, this blood comes here and the same pressure is maintained in the artery walls. Now this is, as it is giving pressure, you see the direction of the arrow, it is giving pressure, the artery is dilating and the blood is pushing. The blood is pushing. So if these arterioles are normal, the blood will flow normally. So peripheral resistance is the resistance which is offered by the arterioles. If the arterioles are constricted, there are some medicines, there are some diseases when the arteriole gets contracted. Constriction of the arterial wall. There are some medicines which can produce vasoconstriction. So if there is a vasoconstriction, due to this vasoconstriction, the resistance increases and the pressure will be high. If the resistance is normal and this is pressing normally during systole, the same pressure will be carried over to the artery wall, or this artery one will measure this artery wall from the brachial artery. We measure the blood pressure in the brachial artery, big artery, and the pressure will be 120 Hg. But it relaxes. What happens when it relaxes? When it is under diastole. So there is a diastolic condition, heart is relaxing, heart is swelling. So when it will relax, what will happen? Blood will come from the atrium to the ventricle. But this valve will close because when it will relax, the blood will try to push back. Blood in the arteries will try to push back. You can see this blood is trying to push back, but it is not coming back to the ventricle due to closure of the aortic valve. So what will happen? During diastole, as the pressure is decreasing, but this valve is closed, so the pressure is not decreasing much in the artery walls. Otherwise, what will happen? During systole, the pressure will be 120. During diastole, when the blood will go back, it will be 0. So it is not happening. When during diastole, it is coming back, there is a closure of valve, it stops in the artery. So this pressure with less pressure, but it is continuing in this pressure, and due to this pressure, some part of the blood will go out. This will be diastolic pressure, which normally is 80 millimeters. Because there is no systole, there is no contraction, blood is not coming from here to here. I think it is clear to all of you now.
Which causes the muscle to
This is
contract
the
more
heart rate
forcefully,
into stroke
increasing
volume.
stroke volume, and
That
causing
is
the
the
heart
blood
rate to
volume.
increase.
If the heart
As a
rate will
result,
increase,
cardiac output
the
increases,
outflow will increase.
which causes the muscle to
If the
contract more
stroke volume
forcefully,
will increase,
increasing stroke volume,
blood pressure
and
will
causing the heart rate to
increase. If the
increase.
contractibility will increase, the blood volume will increase. Blood volume will increase, it means the cardiac output is increased. When the cardiac output is increased, the blood pressure is increased. So it depends on these factors. If the venous return is more, the peripheral resistance will be more. If the force of heartbeat is more,
As a result, cardiac
will be-
output increases.
pressure will increase. Frequency of heart rate, if the heart rate is more, it will pump more vigorously, the pressure will increase. If the peripheral resistance, I explained this too, and the blood volume. These are a few factors. When these are more, the blood pressure is more. Now see how this peripheral resistance works. This is a normal vessel. This normal vessel, when it is constricted, you can see this is normal, this is constriction. So when it is constricted, the pressure will be more because the passage will be narrow. And when it is dilated, when there is dilation, vasodilation, the pressure will be less. So if any medicine can produce vasodilation, it will decrease the blood pressure. If any medicine can produce vasoconstriction, it will increase the blood pressure. So these are the two important factors. Peripheral resistance depends on velocity of blood, the speed of blood which is pumping, viscosity, the thickness of the blood. There are some diseases, polycythemia. What happens in polycythemia? The blood becomes very thick. So due to the thickness of the blood, it cannot move properly. The heart has to pump a lot, and then the condition is hypertension. Elasticity of arterial wall in old age, maximum will see this elasticity is decreasing. So the pressure, the blood is not flowing properly, and it causes high BP. Lumen of the blood vessel. If the lumen of the blood vessel is narrow, what happens in old age? There is arteriosclerosis, there is atherosclerosis. Arteriosclerosis is thickening of the artery wall. Atherosclerosis is deposition of cholesterol in the artery. In both cases, the lumen of the blood vessel is decreasing, causing hypertension. So normally, what kind of hypertension which we will get? That is the most common. The blood pressure are essential hypertension and secondary hypertension. In our practice, we will get two types of blood pressures. One is essential hypertension, one is secondary hypertension. But above all, you can get isolated systolic hypertension. This is in old age when due to the atherosclerosis, arteriosclerosis, only the systolic pressure is high, but the diastolic pressure is normal. When you measure the pressure, it will become 170 by 80, 170 by 90. So systolic pressure will be high, diastolic pressure will be normal. That is known as labile systolic hypertension, isolated systolic hypertension. Labile hypertension is not common, but dangerous because the blood pressure fluctuates very frequently. Sometimes it is 120/80, sometimes 140/90, sometimes 160/90. So this fluctuation without proper causation or known cause is known as labile hypertension. There is malignant hypertension when it is related with some serious problem. And white coat hypertension is very common nowadays, especially in these young blood who are working overnight, who are working regularly on laptops and all that. So they are very tense, and when they go to doctor, they will go to the doctor due to that psychological problem. That the doctor will see my blood pressure and it will be more. So due to that tension, the blood pressure increases only that period. So that is known as white collar hypertension. This is the most important slide for understanding the hypertension. If you understand this, you understand everything in hypertension. Nowadays, when people come after a lot of study, they study a lot, they go for Google, they go for everything, they go for good allopathic doctors, and they know how the blood pressure is increasing. They will ask you, and you will have to explain. But you see, these are the causes, these are the reasons why blood pressure, hypertension is happening in our system. So what happens? This is a short thing, not a very detailed thing, but try to understand how the blood pressure increases. Normally what happens when there is, suppose there is slightly low blood pressure, due to some injury, due to some disease, the blood pressure is falling. So how the blood pressure will be more, how the blood pressure will increase. What happens when this is followed, the receptors in kidney, there is a group of cells which is known as juxtaglomerular apparatus. It's a group of cells which is known as juxtaglomerular apparatus. They sense that there is low BP. They understand that there is a low BP, and they secrete one chemical that is known as renin. This chemical is known as renin. And when this this is flowing in the blood. So this initiates the liver to secrete one inactive enzyme, which is known as angiotensinogen. So liver secretes one protein, one inactive protein, which is known as angiotensinogen, which is not active. Now this combines with renin. Renin combines with angiotensinogen and it is converted into angiotensinogen 1. Now angiotensin is active. This angiotensin is active, but it cannot work without further enzyme which is coming from the lungs. That is known as ACE, angiotensin converting enzyme. So in short, kidney secretes renin, liver secretes angiotensin 1, gen which is inactive, they combine and they secrete angiotensin 1. It combines with ACE, angiotensin converting enzyme, which is coming from the lungs. And this makes angiotensin 2. And this yahi root jad hai. This is the root of increasing the blood pressure in your system. So in allopathic, this is out of context, but we must understand they give medicines to inhibit, to reduce the action of either ACE. They say ACE inhibiting medicines. There are some medicines which inhibit, which reduces the action of ACE. When it will not work, it will not be produced. When it will not be produced, there will be no high blood pressure. Sometimes they give to reduce angiotensinogen 2 reducing enzyme medicines. So this angiotensin 2 goes to the blood system and it produces vascular constriction. It produces constriction of the blood vessel. And as I have explained, that when the blood vessel will constrict, the blood pressure will increase. And that is how hypertension takes place. If it goes to the adrenal cortex in the kidney, above kidney there is a gland which is known as adrenal cortex. So adrenal cortex secretes one hormone which is known as aldosterone, which is very important because aldosterone in the system increases absorption of sodium and water. When there will be absorption of sodium and water in the system, the blood volume will increase. If the blood volume will increase, the blood pressure will increase. Third is through the posterior pituitary. If aldosterone goes to the posterior pituitary, it stimulates posterior pituitary to secrete one hormone, anti-diuretic hormone. So urine will not pass properly. The liquid will be stagnated in the anti-diuretic. So the fluid will not pass out from the system. If the fluid will not pass out from the system, the blood volume will increase, the potassium will decrease, and it will cause hypertension. In whichever case you will go, in whichever disease you will go, only these are the factors which can produce high blood pressure. And this aldosterone is very peculiar function that it increases the thirst. So when it increases the thirst, you tend to drink more volume, more water. And if you have more water, if the pressure is low, the blood pressure will increase because the blood volume will increase. So these are a few important points, factors which help you to increase the blood pressure. So now come to the causes of hypertension. I have already described. So there are genetic factors. Essential hypertension is about 70 to 80% of cases when no particular cause is ascertained. You cannot find a peculiar causative factor that how and why the blood pressure is increasing. Only you will find that they are having a family history and sometimes obesity. If there is more fat in the system, the heart will have to pump more and you tend to get high blood pressure. Alcohol intake sometimes, sodium intake sometimes, because sodium is having a tendency to reabsorb water in the. Wherever there will be more sodium, there will be more water and there will be more sodium, there will be more water, the blood volume will increase and the blood pressure will increase. So that is why it is regularly we know that hypertensive patients are advised that take less salt. You advise your patient, if he is having a hypertension, you say, oh, take less salt. There are some more mechanisms which are not clearly understood. I am repeating that they are not clearly understood, but there is sometimes it due to nervous system and this, yes, renin, angiotensin, aldosterone axis, which I showed you, the renin cycle that is known as RAAA, renin, angiotensin, aldosterone axis. Now come to the secondary hypertension. Secondary hypertension is about in 10 to 12% of cases. Rest 80 to 85% of cases are of essential hypertension, where no certain cause is ascertained. But in this case, you will find secondary hypertension. What happens? Decreased compliance of aorta. This is the aorta. So if aortas are having atherosclerosis, what is atherosclerosis? These are arteries. There is a deposition of cholesterol in the artery walls and they become narrow, and you will see it is becoming narrow and narrow and narrow. So the blood flow is stopped or obstructed, and due to this obstruction, the blood pressure increases. This is one important cause of secondary hypertension. Next is aortic regurgitation. What happens? This is a disease when there is a volume overload. What happens in aortic regurgitation? You must be knowing. This is heart. This is aortic valve. This is aortic valve. Normally, when the blood goes from the aorta, it should not come back. But if these valves are weak, some part of blood comes back to the heart ventricle. You are seeing here, this blood is coming back. So this is known as aortic regurgitation, going back to the ventricle. And when it goes back to the ventricle, the volume is more in the blood and the pressure, the heart has to pump with more pressure, that causes hypertension. This condition is known as aortic regurgitation. Sometimes in case of hyperthyroidism, thyrotoxicosis, in case of hyperthyroidism, you will see when the patient is having hyperthyroidism, he is having pulse rate, more pulse rate. The pulse rate is very high. So when there is a pulse rate very high, due to the high pulse rate, there is cardiac output is more and the blood pressure will be more. Now, this is very important. You will see in all kidney diseases, there are so many kidney diseases where blood pressure automatically rises due to renin angiotensin action. I told you that whenever there will be problem in the kidney will start to secrete renin. It will go to the liver, mix with angiotensin 1, angiotensin 2, and then increase the blood pressure from the different angles. But in all kidney problems, the most important part is there is activation of RAA system, renin angiotensin aldosterone axis. You can see renin plus angiotensinogen in liver forms angiotensinogen 1. In lungs, angiotensinogen is converted into angiotensin 2, which is a vasoconstrictor. So wherever will be vasoconstriction, blood vessel will be constricting. Whenever it will be constricting, the blood pressure will be high always. So this is one disease, renal artery stenosis. If there is stenosis of the artery, so stenosis is constriction. So if there is constriction of the artery, the blood pressure will increase. Chronic pyelonephritis due to infection, glomerulonephritis due to problem in the nephron. All these are renal causes. Polycystic kidney disorder, renin producing tumor. So you can see all these, which I showed 5 to 6 kidney problems. In all these diseases, there is activation of RAAA. There is more renin. The more renin, the more production of aldosterone. More production of aldosterone, more reabsorption of sodium and water. So there are some sodium channels, there are some potassium channels. So there is sodium is increased, potassium is decreased. So there will be low potassium, there will be high sodium, there will be more water, reabsorption of water, and that will cause hypo. This is when there is anti-pituitary is affected. In some cases, you can see endocrine anti-pituitary. In case of myxedema, acromegaly, in both cases, there is accumulation of water in the system. You can see the swelling. These are the swelling due to the absorption, fluid retention. So this fluid, it will be retention, there will be fluid, there will be more blood volume, and the patient will have to get hypertension. Now, adrenal, which we have already discussed, there is adrenal cortex, the adrenaline and norepinephrine. They increase the heart rate and carbon dioxide absorption. This is not very common, but this is very common. Aldosterone. This is the root. Aldosterone, there is more water retention, there is more sodium reabsorption, and ultimately the blood pressure is increased. And if there is more cortisol, in the aldosterone system, then there will be water retention, there will be activation of RN. You see, I am repeating and repeating and repeating that in all causes of hypertension, there is activation of RAAA. So please understand what is RAAA. In practice life, it is of very use. There are some drugs which can increase the blood pressure, that is oral contraceptive, cyclosporin, steroids, and NSAID. So these are the 4 kinds of drugs which has been observed that they may cause hypertension if they are used on regular basis. Now there is a very rare disease which is known as coarctation of aorta. You will get the cases. Patient will come without having any knowledge, but his blood pressure is not reducing. So he will be having constant high blood pressure, but this constant high blood pressure, sometimes, rarely, it is not a very common disease, but this is known as coaction of aorta. This is the aorta which has the branches going upwards and going downward. This is the aorta which is supplying blood. Sometimes it goes upward and it supplies downward. So if there is a constriction of this part, what will happen? The blood will come here, go here, but not come here. So where is the blockage? The blood pressure here will be more, and blood pressure here will be less. So in one body, one person you will find, in one hand the blood pressure is more, in other hand the blood pressure is less. Very rare disease, but it is found. You can see how it happens.
Arches around to head downwards through the chest and lower body. As it arches around, it gives off arteries to the head and arms. Coarctation of the aorta is a narrowing of a part of the aorta.
Becomes narrow.
Most commonly,
now the blood is not flowing
after it has given off the branches.
Blood is going here in place of coming here. It goes there. So in this area, the blood pressure is high.
Become evident at any age.
The blood pressure
if the narrowing is very severe, it can become obvious shortly after birth. When poor blood flow to the lower part of the body can cause small babies to become very unwell. Arches around to head downward.
Some of the other causes of hypertension are that increased blood volume due to excessive transfusion and polycythemia vera. If excessive transfusion of blood is given, the blood volume will increase in the body. Blood volume will increase, the blood pressure will increase. In case of polycythemia, what happens? The blood becomes very thick. The blood becomes, RBCs become very thick. So due to the thickness, the viscosity of the blood increases and blood cannot pass from the artery. So heart has to pump a lot with high pressure to pass that blood into the system, and due to that reason, the blood pressure increases. Toxemia of pregnancy, in pregnancy, sometimes it is found, and sometimes it is psychological, neurogenic, psychogenic. Sometimes due to stress, due to tension, due to unknown reasons also, the blood pressure is found to be more. And what will be the clinical features? So, I think roughly you have understood the causes of the high blood pressure. So, but what will be the symptom? You have understood the cause, that there is some relation between the renin, angiotensin, aldosterone, etc. in the system. The causes, so some causes we have already discussed. Now the symptoms. What will be symptom the patient will be getting? The high blood pressure normally gives you some symptoms which are very common, that is occipital headache. Patient will complain that when I get up in the morning, I get headache in my occiput. So that is first indication, but nobody bothers exactly immediately. Oh, okay, we will see. But if a patient complains to you that I don't feel normal when I get up, I feel very heavy, because when the patient sleeps, the blood circulation is in the brain. That is why when he gets up, he gets dizzy and occipital heaviness, dizziness, palpitation sometimes, and easy fatigue ability. The patient will complain, I feel very tired. I don't feel energetic. I feel very tired. I feel occipital headaches in the morning. So that is the first point where you should immediately check the blood pressure of the patient. If the hypertension is due to some other diseases, essential hypertension will have the symptoms, mild symptoms, not very serious symptoms. But if it is associated with some other diseases, like you can see, then it can happen epistaxis. If the pressure is very high, there may be nose bleeding. And so people say, if the patient has bled from the nose, it means he has survived. Otherwise, there may be chances of brain hemorrhage. So if the patient comes to you with epistaxis or episodes of epistaxis, the patient says that I am having sometimes nose bleeding without any cause, it stops immediately, then again it comes back. Check his blood pressure. Hematuria when kidney is associated. I have told you the kidney is the first factor when you have secondary hypertension, not essential hypertension. Secondary hypertension, when the blood pressure is due to some disease, think about kidney. Blurring of vision, when the blood pressure is going more in the eyes. Episodes of weakness or dizziness due to transient cerebral ischemia. What is this? Transient cerebral ischemia. What happens sometimes that there is for a fraction of a second, the blood supply stops into the brain. So when there is sudden stoppage of blood supply into the brain, the patient feels giddy. So that giddiness is due to ischemia, transient ischemia, small second. There is lack of blood supply in the head. Patient will come to you, but when I get up, I suddenly feel giddy. Check his blood pressure. There may be transient ischemia. There may be angina pectoris. So angina pectoris is when the patient is having cardiac problems and having pain in the chest, especially when he tries to move, tries to walk, tries to talk, tries to laugh. So there is pain in the chest. Symptoms due to underlying diseases in secondary hypertension. I am repeating that underlying cause, clear-cut cause will only be visible in secondary hypertension. In essential hypertension, normally we don't find direct causes. It is due to stress, it is due to genetic factors, it is due to its particular constitution. We'll be discussing the treatment of these things also. But underlying disease, when there is polyuria, polydipsia, and muscle weakness, secondary to hypokalemia in patients with primary aldosteronism. I have discussed this point because when the aldosterone works, So aldosterone, when is high, it has the tendency of having reabsorption of sodium and water into the system, and potassium is excreted. It opens the potassium channels, it opens the sodium channel, reabsorbs sodium, excretes potassium. So that condition is known as hypokalemia. And if there is hypokalemia, lack of potassium, there will be several symptoms, especially weakness and other parts. Go for a blood test. There is weight gain and moon phase in Cushing syndrome. Cushing syndrome, we know, it's due to anterior pituitary problem. And in this case, there will be severe weight gain and moon phase. There is headache, palpitation, sweating, and postural dizziness, phenochromocystoma. This is a very rare disease which we should not care much about. It's a tumor. This tumor, normally they have headache and palpitation, but all these things are due to secondary hypertension. So now complications of hypertension, there will be cardiovascular complication, cerebral, brain, ocular, eye, renal, kidney, hemorrhages, extremity. What will be that? You see, there will be in the heart, we will come. So there is in heart, there will be ventricular hypertrophy. If this is the ventricle, so this ventricle is pumping a lot, pumping with more pressure. This is a normal right ventricle. This is a left ventricle which is having hypertrophy. You can see this is hypertrophy. Thick ventricular wall, rest of heart is normal. So this is a thick ventricular wall with hypertrophy, left ventricular hypertrophy. This is due to high blood pressure because the heart is pumping much. When you will go for an X-ray, you will find the doctor will write in the report that there is left ventricular hypertrophy. It can be detected by the X-rays, and this is the chest pain during angina pectoris. This is myocardial infarction. When a part of the heart becomes dead, this part is becoming dead. This is the cardiac muscle, and this is the ventricle. So one part of this ventricle, this yellowish part, has become dead. That is myocardial infarction, heart attack. So what happens? In case of myocardial infarction, if this part is not working, the heart will have to pump with more force because some part is not working. Some parts become dead. So due to death of that particular part, the heart will have to pump more and it will cause hypertension. This is a rare disease, abdominal aortic aneurysm, but you must know the aorta is supplying in the abdomen also, and it's very strong. The aorta is very strong in the abdomen because it has to supply on the lower extremities. Sometimes in the abdominal area, one portion of the aorta swells up. There is swelling of one portion of the aorta, and if there is a swelling, the patient will complain of pain in the abdomen. So normally we will not doubt anything, but during cardiac inspection, it will be clear that there is some problem. You can see
the aorta may weaken, slowly bulging outward like a balloon. The aorta may weaken, slowly bulging outward like a balloon.
So this kind of
the
swelling,
aorta may weaken,
bulging
slowly bulging outward
in
like
the
a balloon.
aorta. This is known
The aorta may
as
weaken,
abdominal aortic
slowly bulging outward like a
aneurysm.
balloon. The aorta may weaken. The aorta may...
In the cerebral part, what will happen? We are discussing the complications of high blood pressure. The cerebral part, we already discussed the transient ischemic attacks. We have discussed this part. Cerebral infarction, if the blood pressure is very high, one part of the brain may be dead. It happens so many times, it may cause paralysis and so many other complications. There may be cerebral hemorrhages. This is cerebral hemorrhage. That the blood pressure will rupture and there will be bleeding inside the brain. We are having good medicines for this. We will discuss later on. But this is the complication of hypertension. And hypertensive encephalopathy, very serious problem. If the brain is suffering with encephalopathy, there is disordered consciousness. Patient will be unconscious, increased intracranial pressure, retinopathy with papilloedema. This is a complication in the eye, and there may be seizure, epileptic attack. This is a very serious condition. Hypertensive encephalopathy. Our few good medicines we are having, like Helleborus, lachesis, arnica. Arnica is a good medicine in this case of cerebral hemorrhage. Arnica, hemamelis, lachesis are the good medicine. But in this case, the medicine is arnica, Helleborus. And retinopathy with papilloderma, we will discuss that. Now, come to the kidney complications of hypertension. The kidney complications are, as we discussed, that there will be more sodium channels, less potassium channels, and disturbance in the kidney functioning. So there will be proteinuria, passing of albumin or protein with the urine. If kidney is damaged more, then there will be hematuria. Microscopic hematuria, the blood will be not visible by naked eye. Only during the microscopic examination you will find. There may be kidney failure. There may be renal arteriosclerosis, very rare case. Renal infects are also very common, less common. Now come to the eye complication. When there is a complication in the eye part, what will happen? There may be retinal infarct. You can see this part. Like we have discussed the myocardial infarction, when a part of the myocardium becomes dead. So in the retina, when a part of the retina becomes dead, it is known as renal infarction. And sometimes there is a bleeding. You know, these are very common cases. So this bleeding, there is a bleeding. So this bleeding is a retinal hemorrhage. This is retinal infarction. In case of retinal hemorrhage, one of the best medicine, Bothrops. Bothrops is very good for controlling this. And then renal infarction, less medicines are common because this is not curable. So these parts become dead. So this is not curable with medicine. So there is papilloedema. Due to regular blood pressure, some part of the intracranial pressure, a part in the eye becomes swelled up like this. It's swelling, there is swelling like this. So with the swelling like this is known as papilloedema. And in extreme cases, it may cause blindness. And there is one more complication that is in the extremity known as arteriosclerotic gangrene. If there is severe arteriosclerosis, what will happen? In the lower extremity, what will happen? It is associated with diabetes so many times. Due to the arteriosclerosis, there is less of the blood flow. The artery becomes thick. The artery wall becomes thick. They do not have the constriction and dilation properly. So some part of the lower extremity, it dies. It forms gangrene. And due to this condition, there is arteriosclerotic gangrene. Lachesis, pickle cough. These are the two best medicines if you want to treat and if it is treatable. And first of all, treat the hypertension. So these are a few complications of the. So what investigations we will do? Urine analysis for hematuria, proteinuria, creatinine to check if there is whether renal failure or not, ECG for left ventricular hypertrophy and ischemia. If there is left ventricular hypertrophy, he is suffering from hypertension. If there is ischemia, the patient will suffer with pain in the heart, that is angina pectoris. Chest X-ray for coarctation. Coarctation of aorta is not really very easily diagnosable by chest X-ray. But sometimes due to its pressure on the ribs and other ones, because it comes with birth. So it is very difficult to diagnose by chest X-ray. The other more advanced test will be followed. Yes, chest X-ray can help you in cardiomegaly. If there is enlargement of heart, sometimes I told you that in X-ray you will find there is enlargement of the left ventricle. Sometimes if the condition is very severe, then there will be enlargement of the complete heart, that is known as cardiomegaly, and sometimes there will be heart failure. Plasma, I told you, plasma electrolytes. Why? proper sodium is there, proper potassium is there, proper other salts are there. Whether they are properly there or not, this will be tested by, we test for serum electrolytes. So they test you serum sodium, serum potassium, and other salts. So if there is any deficiency in these salts, you'll have to prescribe medicine or do other things. Ultrasound of kidney. So ultrasound of kidney, why? If there is pyelonephritis or other complications in the kidney. I told you, when you go for a secondary hypertension case, always think about kidney. Kidney is the most favorite part from where the secondary hypertension starts. 24-hour urinary catecholamines, metanephrine, this is not very common. Plasma renin activity and aldosterone, this also is not a very common test which we do. Yes, endocrine test we can do for Cushing syndrome, acromegaly. For these two tests, we will have to test the pituitarian level, serum pituitarian level. And for thyroid diseases, we'll have to do the thyroid function test. The proper T3, T4 are normal or not. In case of TSH, high TSH, the hypertension doesn't take place very commonly. But if T3, T4 are high, then the condition is thyrotoxicosis, and you will get high blood pressure with very high pulse rate. And if there is high pulse rate, there will be high blood pressure. These are very advanced tests which we'll have to go. That is angiography. This is what I am telling. Coaction is suspected, then it cannot be diagnosed normally by X-ray. You will have to go for angiography or a PAM. It's a very serious problem. Plasma lipid profile sometimes helpful, yes. So now this much is all about the high blood pressure. In the next class, we will discuss the treatment part of the hypertension, homeopathic treatment plus the management. So thank you very much for listening to me. And if you have any question, you may please ask.
Thank you, sir. Thank you so much. And the participants, if you have any question, you can raise your hand and ask question to Dr. Kulwant Singh. We have 5 minutes more to ask question. If you have any question, means you can put in the chat box also. Which medicine are more useful in increasing diastolic blood pressure, sir?
We will be discussing all these things in the second part. No?
Okay, okay.
I told you that we will discuss.
No, sir. There is a question in the chat box. I was reading the question.
If you want to increase only the diastolic pressure, but normally it is not the case. You will not find a case where only diastolic pressure is high and systolic is normal.
Okay.
But sometimes medicines, if there is some damage to the heart, if it is related to some heart problem, then digitalis 3x is one of the best.
Thank you, sir. Actually, it was a wonderful session and detailed explanation even. So I think
we will discuss the treatment part in detail.
Yeah, exactly. That's before beginning the session itself, Sahani sir told that we are taking the session as a 2-part. When is the next session?
After 15 days. After 15 days.
After 15, okay.
Next week, I am having the treatment part in Hindi in your session.
Okay. Those who can understand Hindi, they can watch Hindi session also. We will start the Hindi session at 7:30 in the evening. So those who can understand, you can watch in the Hindi also, because most of the faculties coming from Hindi are sharing their knowledge in English also. So while watching both the session, you will get more idea about the subject, and you will be thorough about the portion. And Dr. Ram Parvesh sir, what do you want to tell? You have written something in the chat box.
Thank you, Dr. Anjani, and thank you. Good evening, everyone and congratulations हमारे डॉक्टर कुलवंत सिंह सर जी. Very nice presentation, excellent session. Every session is a dynamic lecture. Very good describe of disease, hypertension, hypertension, cause and symptom. Very, very thanks and congratulations, Dr. Kulwant Singh ji. Thank you.
Thank you so much, sir. And someone is asking about the YouTube channel. We have you have to type IFPH. So if you miss some portion and if you have any doubt in the portion, means you can watch the YouTube channel also. You subscribe the channel IFPH. Just type IFPH. So you can again and again watch the classes that we are taking here. And if you want to watch the same session again, means you can, tomorrow onwards, it will be available in the YouTube channel. Okay. Some are asking. Can we see again in the YouTube? We missed some part. No problem. You can watch tomorrow. You can watch the session. If you are asking in the chat box, I think you might have been in some particular group, no? Like Hindi group, Trivandrum, Ernakulam and all. In that group also you can ask. Someone will share from the YouTube also. If you are lazy to check in the YouTube, means you will get the link directly. Okay. So I think it is the time to wind up the session. Dr. Shafiq, are you available? Dr. Shafiq? Okay. Dr. Vivek Kumar Mishra, you're watching from the beginning. So I'm inviting you to give vote of thanks to Dr. Kulwant Singh. You can unmute yourself. I'm sending.
थैंक यू वेरी मच सर. आज का सेशन सर बहुत ही अच्छा था सर. हम तो आपको कॉलेज से सुनते आए हैं, आप हमें पढ़ाते भी रहे हैं सर. आपका लेक्चर तो हर समय ही इंफॉर्मेटिव रहा. और सर बहुत अच्छा रहा कि आज का सेशन हम लोग के लिए हाइपरटेंशन पहले भी आपके द्वारा समझाया गया था. आज फिर से एक बार सौभाग्य प्राप्त हुआ कि इससे अच्छा हम नहीं सुन सकते थे, इससे अच्छा हम नहीं समझ सकते थे. वेरी वेरी थैंक यू सर.
Dr. Vivek, are you the student of Dr. Kulwant Singh, sir?
Yes, ma'am.
Yeah, from the beginning, I am watching. In your eyes, there is a particular respect, and you're watching with with happiness and respect. So I invite you to thank you so much. Thank you so much, and thank you, sir, on behalf of IFPH and from myself. I'm thanking you. Now it is a time to thank you. Thank you so much. Okay, we'll see you tomorrow in the same time. All of you subscribe our channel, watch daily, have to join the sessions. So that will be more inspiration for IFPH. Every day IFPH's family is growing. That is pride for IFPH. Thank you so much. Love you all. Good night. Now I am inviting Dr. Mariamma John. She is the moderator of Malayalam session. Dr. Mariamma John, please, I am welcoming you.